stages. Coming to anthropometry, height is 102 falling under third centile, that is count. Weight is 17 kgs between third and 10th centile. BMI 10 to 25th centile. Upper segment is 54 centimeters and lower segment 56 centimeters. Upper segment, lower segment ratio is 1:1. Chronological age of 8 years, whereas height age is 4 years. And coming to mid-parental height, the expected target height is 155.2 centimeters. And when it was for Turner syndrome, we look for hypertelorism, low set ears, and white-faced nipples. Cubital valgus is there. In case of Russell-Silver syndrome, we can look for clinodactyly luminance.
What are the features of Russell-Silver syndrome?
Russell-Silver syndrome, child will have short stature. Their head size appears larger, but on measuring it will fall between the normal centiles only. Which develop intellectually, child will be normal with clinodactyly with undescended testes.
More than that, what is it?
Broad forehead.
Triangular type. Pointed. Cryptorchidism.
Cryptorchidism
is very active. Any other syndromes?
What
are the shock syndrome? SH4X. Short stature, obesity, higher. Any others?
Prader-Willi syndrome.
Any others? Okay, here
Downs.
Here you have mother with hypothyroidism. This baby has short stature. What do you mean by decreased growth velocity? What is the normal growth velocity? When do you evaluate a child?
Normal growth velocity is like in first 1 year, the growth will be approximately 24 to 25 centimeters per year, sir. In the second year, it will be half of that, like 12 to 13 centimeters per year. And in the third year of age, it will be half of that, 6 to 8 centimeters per year. After third year, the velocity will be 4 to 5 centimeters per year.
Yes, you are right. As a rule of thumb, what we have to remember, yeah, child is between 2 to 4 years. When you say decreased height velocity, it means if it is less than 5.5 centimeters. So any child between 2 to 4 years not gaining 5.5 centimeters per year. That is a short stature. That is decreased growth. That is decreased height velocity. Whereas if you see between 4 to 6 years, any child not growing more than 5 centimeters per year. What we know, the rule of thumb is any child not gaining height of 4 centimeters or more per year between 6 years to puberty. So what all we know is the 4 centimeters from 6 years to puberty. So a child is expected to grow at least 4 centimeters per year from 6 years onward. Before that, it is 5 centimeters between 4 to 6 years and 5.5 centimeters between 2 to 4 years. That we have to know. Yes, proceed. And this mother had hypothyroidism. In general examination, apart from dysmorphology, what all you see in the child?
We'll ask for
specific, yeah.
History of we'll ask for history of constipation.
Over in examination, in the examination.
Dry skin. Any dry
skin for the features of hypothyroidism. What are glaring for ITS child? Yeah.
Shiny skin.
Yeah. Dry skin.
Yeah. Protruded abdomen.
Protruded abdomen. Umbilical
hernia.
Yeah. Hoarse voice. Most of the time, this is one disease which you can, in Titan, I read about 25 years. This is one disease you can diagnose on phone. The child will have hoarse voice, especially the more the adolescents, they have more hoarse voice. This is the disease which you can diagnose on phone. That time I didn't understand because we never used to have phones 25 years back, right? And very important is
Goiter.
Goiter.
In the-
If the child has goiter, what is the disease? What is the likely disease?
Good. Likely, it can be Hashimoto's thyroid, sir.
Oh,
Like
whenever
goiter,
this type
or
of
it can be
child-
endemic goiter.
You think of dysharmoniogenesis. Dysharmoniogenesis, where there is hypertrophy of the, apart from the physiological changes, physiological goiter, think of dysharmoniogenesis, especially when the child has
Here.
deafness, then it is called Pendred syndrome.
Pendred
This you know. Goiter with the deafness, in this age is a Pendred syndrome with the keeping in history of mind, in the background of the mother's hypothyroidism. Please proceed.
These are the growth charts. Height for age, which is less than 3rd centile, and weight for age between 3rd to 10th centile. BMI between 10 to 25th centile. On systemic examination is normal, sir.
Okay.
All GAT, respiratory, CVS, and central nervous system examination is normal. Coming to summary, 8-year-old developmentally normal girl child, second in birth order, born out of non-consanguineous marriage, with proportionate short stature, with normal systemic examination, with no history of recurrent or chronic illness, with adequate nutrition.
Okay, the case is open for discussion. Anybody wants to discuss? Any pages from Paramita Hospital? Approach to short stature? Anyone want to volunteer from Ankur Hospital? For want of time, let's proceed. What are your possible probable time?
From history and examination, first, because this is a case of short stature, and on anthropometry, we could make out it is a proportionate short stature, where there is no history of recurrent or chronic illness, and weight is less affected than height. So, like height age is more affected than weight age. We were mostly thinking of endocrine causes, sir. And since it is a female child with short stature, syndromic causes or Turner's was also suspected. So endocrine causes more likely hypothyroidism, or it can be panhypopituitarism. But panhypopituitarism, there should be features of midline defects which were not there. So more likely hypothyroidism and Turner's. Acquired hypothyroidism and Turner syndrome. On examination, complete hemogram, renal function test and liver function test are normal. Thyroid profile, T4 was low, sir, with TSH elevated more than 150 microinternational units per ml. And bonage was decreased. We don't have X-ray.
What is the atlas called? For bone age?
Grillic file atlas.
Do we have it? Right.
This Murthy used to ask us spelling.
Yes. Can you tell the spelling?
GRULIC.
That is E also.
EU.
That is E also. And 5.
PYLE.
Yes.
Karyotyping was done to rule out Turner.
Like, can you tell the rule of thumb? How many carpals per age? You can just look the other pages who are on the Zoom.
Roughly we'll calculate it as like age minus 1. Age minus 1 could be the number of carpal
So if
bones.
it is 8 years child, how many carpal bones you need?
Minimum 7 should be there.
So is that the norm now? Is that the way you will estimate the age now?
What is the current guideline?
How is bone age estimated these days? Huh? You know about Tanner staging? There is Tanner's method of estimating bone age.
Tanner items.
So what is that? No idea. So what you do is it's a very simple technique, and there are apps also. Nowadays there are apps. So you look at the phalanges and look at the epiphysis. Okay. Compare to the phalange how the epiphysis. If the epiphysis is less than the phalange, is it gone up to the phalange or gone beyond the phalange? And the distance between the phalange and the epiphysis. So these terms will help us to identify the age of children. No more carpal bones are to be used. Okay, no more. This should be the way to diagnose the bone age. So there are good apps, there are atlases which will help you, and it gives an accurate age. So we are not supposed to use any more carpal bones. Okay.
USG neck was done where thyroid gland was hypoechoic with increased vascularity, features suggestive of inflammation, probably Hashimoto's thyroiditis. USG abdomen and pelvis was done to look for any streak, ovaries, and size of the uterus, which was normal. And coming to antibodies, anti-thyroid peroxidase antibodies were positive, which were elevated, and anti-thyroglobulin antibodies were also positive.
So why did you do the other one?
Because it is a female cell, we wanted to rule out other autoimmune condition. We did ANA antibody as well. And so we diagnosed it to be a case of Hashimoto's thyroiditis, which is an autoimmune thyroiditis, usually presenting in this age group, like 8 to 19 years. Adolescent group is the most common age of presentation. We went back and investigated the sibling also, elder sibling who is 9.5 years of age, where the USG neck was showed altered echo texture with mild increase in vascularity, but the antibodies were mildly elevated. So we are following up that elder sibling also. Yes. And later, like mother was a known case of hypothyroidism, and she is on thyronorm. When mother ultrasound was done, it was suggestive of Graves' disease, and even mother T2 antibodies were positive. So it is a case of familial autoimmune hypothyroidism, which is running in the family. There is like 25% incidence, like one sibling is affected. 25% chance that the other sibling or the mother is likely to be affected with this autoimmune cause.
So, this is a good case. I congratulate Dr. Sandhya and Dr. Preeti, the team of for presenting a not uncommon case. So many children will keep coming to us with constipation. That is a red flag. So children with constipation, that is not miss a easily treatable, easily monitorable case which we can prevent the mental retardation disease. Take home message is, let us continue to screen for hypothyroidism. Now, what are the neonatal guidelines for hypothyroidism to diagnose central hypothyroidism? Anybody? Do you want TSH or you want T4 with it or T3? What are the current guidelines?
TSH will look, sir.
Yeah. How much it should be after 72 hours?
After 72 hours, more than 20 is significant. For 2 weeks, after 2 weeks, more than 10 is significant.
In what way bone age is useful for hypothyroidism? As I was clearly told about bone age. In what way it is useful? In the newborn, which X-ray will take to diagnose the hypothyroidism?
The X-ray will look for distal femur and proximal tibial.
If you are a peripheral center, when you have sent a sample for thyroid analysis, it may take some time. Meanwhile, you could take an X-ray when you need 4 epiphyses for both the knee joints. If 2 of them are absent, a strong pointer for congenital hypothyroidism, and it is not only as a screening test, but it can prognosticate. Means it is more severe because of the delayed bone age. It means it is more severe and more early in utero onset, and the prognosis is not up to the mark. Those children who have delayed bone age, the prognosis is not very good. Still, they may have some dyslexia, mental retardation, even if you are treated early. Right? Well presented. Let us applaud for Team Nilofer, Dr. Sandhya. Move to the next case. I invite Dr. Narayana, pediatric surgeon from Nilofer Hospital. Sir will be dealing about extrapulmonary sequestration in congenital diaphragmatic eventration thoracoscopic approach. What is the neonatal presentation of diaphragmatic hernia? Anybody? Dr. Sandhya, when do you suspect diaphragmatic hernia? How does it present?
Most of the time,
Diaphragmatic hernia, clinical present. When do you suspect?
When the silence has respiratory distress. Not the patient. Not coming
Oral cavity, secretion, especially abdomen, TOF, then abdomen, look of the abdomen, good abdomen. What are the do's and don'ts if you are resuscitating a newborn baby? What we should? Bag and mask is coordinated by. So yes, what is indicated for it if you are asked to resuscitate, attend a delivery for congenital diaphragmatic hernia? NG tube decompress the abdomen and tube and bag ventilation. No one for that. This was the candidate. Now I invite Dr. Narayana Garu to take us through congenital diaphragmatic eventration with extrapulmonary sequestration. Your attention to Dr. Narayana.
Thank you all. Today I would like to present a rare presentation. Usually congenital diaphragmatic hernia and pulmonary congenital anomalies association is not new. There are many cases, but in evacuation with pulmonary sequestration is very rare presentation. So I would like to share my knowledge with you and the approach which we operated this case. So congenital diaphragmatic eventuation with extrapulmonary sequestration. By definition, pulmonary sequestration is a condition in which the segment or a lobe of dysplastic lung tissue with no communication with the rest of the tracheobronchial tree and receives an anomalous systemic vascular supply separate from the rest of the lung. It's usually a non-functional tissue and it was first described by Price in 1946. And the pulmonary sequestration is thought to account for less than 6% of the congenital lung malformations. Is of two types, intralobar and extralobar.
And there, be there. So then, change something and write out.
Share with this one.
Okay.
Intralobar sequestration, it is characterized by presence within the visceral flora of the functioning lung tissue, and its venous drainage into the pulmonary vein, and more common in the left lower lobe. And approximately 2/3 of the intralobar sequestrations are found in the left lower lobe. It's more common and has a reported incidence of 75 to 86%, and much more common than the extralobar pulmonary sequestration. And the extralobar sequestration. Extralobar sequestration has a separate visceral pleura and venous drainage, and its venous drainage is into the systemic veins. Its arterial supply is most commonly from the descending aorta, 73%, and they are often found between the diaphragm and the lower lobes of the lung, and rarely infradiaphragmatic. Coming to the etiology, sequestration is a congenital anomaly of the primitive cut. The most plausible theory is the formation of an accessory supernumerary lung bud below the normal lung bud, and it continues to migrate caudally within the esophagus in extralobar sequestration, and then derives its blood supply from the primitive splanchnic vessel surrounding the foregut. If the lung bud arises from the development of flora, before the development of flora, it results in intralobar sequestration. Here I am presenting a 2-month-old male baby with the recurrent attacks of lower tract infection, lower respiratory tract infection. Upon investigation, found to have left congenital diaphragmatic eventation. X-ray was taken, CT test was done, but none of them showed any evidence of SOL in the left lung. So a thoracic repair of eventation done, but the extrapulmonary sequestration could not be recognized. Could be recognized only after completion of the procedure. The vascular pedicle doubly ligated, excised and removed, sent for HPE. Here you can see the CT chest, an extreme left diaphragmatic eventation with spleen and all pushed above and occupying almost more than half of the left chest. And the CT report, there is no mention of any sequestration, any SOL in the lung. And this is post-operative picture. You can see beautifully repaired left diaphragm. It is almost looking like a normal diaphragm on the left side. Yeah, that is the extrapulmonary sequestration. As you can see, the long vascular pedicle that is coming from the abdomen. That is a junction of the diaphragm with the chest wall. And here you can see the repaired eventation. There is a repaired eventation. There is a completely repaired eventation, you can see beautifully. And here I am ligating the vascular pedicle with a suture. And this is doubly ligated and then cut and removed. Pulmonary sequestration is frequently associated with other anomalies, most commonly the diaphragmatic hernia. A research of the peer-reviewed literature shows there are about 7 cases congenital pulmonary sequestration with eventation. That 4 of them are with extralobar sequestration and 3 with intralobar sequestration. And take-home message: extrapulmonary extralobar pulmonary sequestration is associated with congenital diaphragmatic hernia, diaphragmatic eventation is extremely rare condition. It tend to miss the lesion when operated by routine laparotomy, as it lies above the diaphragm intrathoracically. Even pre-operative CT chest could not give an indication of its presence. So because it was operated with thoracoscopic approach, it could be removed. A minimally invasive approach is preferred over formal laparotomy, both in terms of less morbidity and less pain, as well as to pick up the hidden lesions in the thorax. Thank you.
Thank you, sir. Thanks for the nice case there. So, like, how common do you see, sir, this kind of case? Because clinically, I think it's very difficult because it's looking like a CDH or a. So, what is the investigational choice to diagnose this in general practice? So,
The investigational choice is the investigational choice is usually picked up by CT chest.
but these
Still there is any doubt, we have to go for the CT angio.
okay.
CT angio will diagnose definitely, because there is no indication that there could be some lesion. So we didn't think much about it. So because out of my interest, I started doing thoracoscopic approach, so I could pick it up. Only after completely repairing that eventually I could pick it up. Otherwise, it was not seen before also.
In 2 months, I think child present with a recurrent respiratory tract.
Yeah. It's normal. You have seen how much it is occupying the chest. It's natural that it will present with LRT and distress, respiratory distress.
Is the child presented with any pulmonary hypoplasia, sir? They say.
And no such hypoplasia. I visited the entire chest wall. The lung is expanding well. You can see that lung how it expanded post-operative X-ray.
Like we say, abdomen is a Pandora's box. Now, chest also is a mini Pandora's box. Thank you, sir, for a good case. Thank you very much. Now,
so the one which is not even visible in the CT chest, so post-operatively, what significant it would have been like if it was not removed?
Okay.
it's a coincidence.
Most of the times it is asymptomatic because it is extrapulmonary. If it is an intrapulmonary, the chance of complications are very high, but the complication wise is very less. So only thing it can undergo torsion and lead to unidentified pain, where the cause could not be identified. If at all it undergoes torsion because of the freely hanging vascular pedicle.
Right, sir. For want of time, let us invite the host hospital team. Your attention to Dr. Vaidehi and Dr. Kiran Karthik. They will be presenting a case on acute flaccid paralysis. Dr. Vaidehi, guide is Dr. Krishna Chaitanya from Ankara Hospital. Over to you, doctor.
Thank even Dr. Kirti, sir, our pediatric neurologist, who was there for managing this case.
Okay, Dr. Kirti. Yeah, we appreciate his input. Yeah, please. Wonderful.
Good afternoon, everyone. Today we are presenting an interesting case of a 3-year-old child who was first in birth order, born to non-consanguineous couple, born by mother with chief complaints of difficulty in standing and walking for the past 8 hours. Santosh. History of present illness.
Please sit there every time. Please.
History of present illness. The child was apparently normal till one day back. Mother noticed sudden onset of difficulty in walking and standing after the child woke up from sleep. He was able to sit independently but was swaying to both sides after a few seconds. He was able to stand from sitting position with minimal support and was able to bear weight. Child was able to lift hands above the shoulder and was also able to hold the objects firmly. But when the child was made to walk, he was walking few steps independently. But then he was swaying to both sides and was requiring support. There was no history of pain, no history of altered sensorium, seizures, headache, photophobia, and speech disturbances. No history of drooping of eyelids, squint, blurring of vision. No history of difficulty in swallowing, drooling of saliva, no nasal twanging voice, no nasal regurgitation of feet, and no change in the volume of voice. No history of deviation of mouth while eating, no history of bowel bladder involvement, and no history of tremors, trauma, animal bite, recent immunization, and no history of fiber. Past history, the child had history of fever 4 days back, which was attributed to viral illness and lasted for 2 days. No history of COVID infection or COVID contact. No history of diarrhea, no history of intake of canned foods and contaminated honey, no history of chicken pox, no history of similar episodes of weakness, no history of sore throat, and no history of drug intake. Antenatal, postnatal history, nothing significant development, child attained milestones appropriate for age, immunized for age, diet history, the child was receiving adequate calories and protein, family history, nothing significant, and they belong to upper middle class. Examination at admission, the child was alert, active, playful, obeying commands, and his vitals were normal. Pulse rate 1 beat per minute, normal in volume.
Can you summarize the history? What are your possibilities in history?
Basically, the child presented with acute onset of unsteadiness in gaits, and he was able to sit with. He was able to sit and stand, but he was requiring support to walk. The possible finding with till now we were confining our differential diagnosis involving the cerebellar system because he was having that ataxic unsteadiness in gait and also a little bit of truncal muscle involvement.
Fever report?
Past history, 4 days prior he had, but at presentation he didn't have fever.
The specific thing was there in your mind when you asked about COVID? You don't know history of COVID.
Even COVID also is presenting like post-COVID, we are seeing acute traffic paralysis also.
How many cases are reported? Be specific.
Anthropometry, the child was weighing 15 kgs, which was at 58th centile and 96 centimeters in height, which was also at 58th centile. Head circumference also was normal. Head to toe examination is like nothing.
It's normal, you can say.
Yeah, neurological CNS examination, child was alert and cooperative, speech was normal, the child was able to tell his name and place.
If there were telangiectasias in the eyes, what could be the likely disease?
Ataxia,
Right?
cranial nerve examination, there will no cranial nerve involvement also. So like
Okay. Fine.
Motor system examination, bulk and tone were normal. Even power for his age, like he was only 3 years of age, so like we couldn't test like partial resistance. That anti-gravity movements were well, so power in all limbs, like we were assigning it as 3/5. Superficial reflexes were present and planters were extensor bilaterally. Deep tendon reflexes, there were 2+. on making the child like on pull to sit, there was no head lag, and when the child was made to sit, no curving of back, but there was mild truncal ataxia. When the child was made to stand, he was bearing weight on legs. There was no genu-recurvatum, and there was mild swaying. And he was able to stand from squatting position with minimal support. When the child was made to walk, he had wide-based gait with swaying to both sides, and he was requiring support to walk. Limited sensory system examination was normal. There were no signs of meningeal irritation. There were signs indicative of, by the end of CNS examination, there were signs indicative of cerebellar ataxia with mild proximal muscle weakness.
What are the other signs of cerebellar involvement?
And we couldn't
No, what are
in general,
what are the other when you suspect a cerebellar lesion?
balance, ataxia, gait, nystagmus,
What type
tremors,
of ataxia will be there in cerebellar?
white-based
You're telling what gait? What type of ataxia?
ataxia.
What do you mean by sensory ataxia? What is Romberg's sign?
Tandem.
What is tandem walking?
When child is made to walk on a straight line with and he's able to balance.
What is this gynokinesia? I'm sure you know everything about the cerebellar signs. What are they? Fast pointing,
Nystagmus.
nystagmus. What type of speech? These are classical Andrea. I'm sure everybody knows it. Scanning or staccato speech, nystagmus. Which side nystagmus? What type of nystagmus?
Same side.
Ipsilateral as the hemisphere. It is not opposite side. Okay. I'm sure you know all this. Tandem walking. Then other tests, the maneuvers we do. Heel to knee test, right? Finger nose. Yes. Okay.
Other systems were normal.
You're done with your case presentation. You want to. So can you localize, because we all want to localize, because this is you want to say that it's a CNS case. Can you localize where is the problem after you finishing the history and come by history and then by your examination?
One is probably cerebellar involvement and element type of
So what are the points clinically saying the cerebellar involvement for this case?
ataxia. And
Only ataxia is there. Okay. Next.
we couldn't elicit other things like
So
tremors.
why can't it be a loss of power or weakness? Why you want to put at ataxia the first thing? Because
Power weakness.
so when you took this case after admission of, I think Krishna Chandra can answer for
Yeah,
this.
it was the entire examination, what she presented was on the day one.
Okay.
Based on those findings, like this is the points in favor and points in against what we framed for our differentials to localize the lesion.
Okay, like do you have any other history adding for it? Because you just said ataxia. So is there progress of ataxia is there involved? Because that gives you more history towards whether which part of the brain is involved or not.
Yeah, we will go to day four.
Okay, okay, fine.
Progression of illness is further described in the next.
Yeah.
Here you are telling the
Yeah. So acute onset of unsteadiness in gait, the possible localization involving the cerebellum is, it could be post-infectious cerebellar ataxia. Points favoring cerebellar ataxia is the recent history of fever, deep tendon reflexes are preserved, swaying of gait, gait was not stable, wide-based, weakness was also not prominent. Points against post-infectious cerebellar ataxia, there were no tremors, speech was normal, and there was also no nystagmus. Now, coming to element, it could involvement of spinal cord, possible because lower limbs are predominantly involved, and against our reflexes are preserved. There's no bladder bowel involvement, and also there's no sensory level. It could be evolving or early GBS because lower limbs are predominantly involved, but against GBS, reflexes are preserved and there's no pain. Muscle weakness, hypokalemia, but there's no contributory history. And myositis, against myositis, there's no pain and reflexes are preserved. Further course in the hospital, the progression of symptoms were like on fourth day of admission, the child was not able to bear weight, not able to sit with support, and when the child was made to sit, he was becoming supine and he was becoming prone and taking help of the hand to get up, and he was not walking even with support. On examination, the child had on making the child stand, he had genu recurvatum and was falling within few seconds. When the child was made to sit, he had truncal curving and hypotonia with anti-gravity movements were still preserved and depend on reflexes are 1+, and there are no root signs. Now the child had evolved like progressive proximal muscle weakness. Again, now post-infectious cerebellar ataxia came down to the down in differential diagnosis with myelitis and GVS coming more favorable, more in favor. Points favoring myelitis are this progressive weakness against our reflexes are preserved with sensations intact and no bowel bladder involvement. It could be GVS because reflexes, sorry, it could not be GVS because reflexes are preserved, and points favoring GVS are proximal muscle weakness. In post-infectious cerebellar ataxia, we do not have progressive muscle weakness. Myositis, still there's no pain and tenderness. Coming to investigation, his serum electrolytes were normal. There was no hypophosphatemia or hypomagnesemia. CPK levels were normal. MRI brain done was normal. CSF analysis and nerve conduction studies were normal. This is MRI spine with contrast showing.
Like actually, before going to the investigation, so what was your probable first diagnosis of this? Because once you do MRI, your nerve conduct studies, you get the diagnosis. But in view of academics, I want to know what is your primary diagnosis and why.
And now it has like acute flaccid paralysis. It has presented into acute flaccid paralysis. With,
so can you tell the definition of AFP?
Sudden onset of weakness in children less than 15 years of age, or if any age when polio is considered.
Suspecting a polio case. Okay. So in this set, the 4 limbs are involved, or what?
Only lower limbs are involved, sir, but truncal weakness was also.
After finishing the 4 days of course, do you find there is any pattern of paralysis in this child, or all the limbs are involved equally?
Ascending paralysis type of picture was.
So can someone answer what is exactly what is the type of presentation in GVS? What do you call? Symmetrical ascending type of paralysis. Any other condition you see typical symmetric ascending paralysis? Also, tell me the other different reactions for AFP, which is like post-infective or something other than
polio.
What is the pattern of poliomyelitis?
Asymmetrical patchy.
Very good. So it is asymmetrical patchy involving one limb when compared to your GBS. Any clinical symptom which gives clues for polio?
Fever at presentation is
very good. So fever generally associated with the presentation of the paralysis in polio when compared to GBS, which present 2 to 3 days after. So what are the other causes of descending paralysis?
Like botulism.
Okay. So what is the history you asked, Sanjay? For botulism, or we are not seeing nowadays because what is the typical history you see in botulism? Or canned foods, because previously there used to use a lot of tetanus or diphtheria.
What is the bowel disturbance in botulism? The constipation is the diarrhea. Yes. Constipation. Any other differential diagnosis for AFP? GBS. Polio. Others are
transverse myelitis and.
What is the hallmark of transverse myelitis?
Early that below the sensory level.
It is transverse. You know, there is a sensory level at the lesion. What are the findings? At the lesion, what are the findings? Below the lesion, what are the findings?
Below the lesion, like sensory cutoff will be there. Bladder involvement, early bladder involvement.
Okay. Other differential diagnosis?
Traumatic neuritis,
Yeah. What are the features?
like history of trauma,
Symmetrical or asymmetrical?
asymmetrical.
Yes, usually it is injection. They say classically the IM site injection, there is a shot on that particular limb is transient.
History of vaccination is important.
Yes. Influenza, like TD vaccination and also like rabies vaccination, meningococcal.
It's for GBS.
Yes.
Then in terms of the injection during the polio, asymptomatic polio, that can also cause paralysis. In terms of the injection can trigger cause paralysis.
What are the different other viruses which can cause polio-like presentation? There is a mnemonic like PACE, yeah, PACE, PAC, P for polio, A for adenovirus, adenovirus. C for coxsackie, E for entero. In that entero also D78. That is the one which affects the pharynx. That is very common. D69, 70, 71. These are the very common. PACE, you remember. And these days, West Nile and Zika virus. That also has to be, when you are sending the investigation, these pieces have to be said. What are the Miller-Fisher variant of GPS? What do you mean by Miller-Fisher variant? Ophthalmoplegia and ataxia. Right? Other Vickers-Staff variant, that is brainstem encephalitis. Then there is another cervicopharyngeal brachial. So all these three will have these anti-GP antibodies. So when these variants are there, Miller-Fisher or Vickers-Staff or pharyngeal, cervicobrachial, they have antibodies against glycoprotein GP. Yes, anti-GP1B. You're right. Okay, let's proceed.
Summarizing, the 3-year-old child presented with ataxia and progressively developing proximal muscle weakness with preserved reflexes and MRI showing cauda-equina nerve root enhancement. Most likely diagnosis is Guillain-Barré syndrome variant with preserved reflexes and GBS disability code. The child was managed with IVIG 2 grams per kg and he responded well to medication, and by 10th day of illness, child was able to bear weight, walk with support, and was able to sit without support. AFP reporting was done and aligned serology and MOG antibodies were negative. At follow-up, the child was able to walk independently and normal. So, GBS with preserved reflexes are seen in 10% of all GBS cases. It is most commonly seen in acute motor axonal neuropathy variant. The proposed mechanism of brisk tendon reflexes is dysfunction of the inhibitory system in the spinal interneurons, and those with preserved reflexes are known to have rapid clinical recovery. Nerve conduction studies, CSF analysis, MRI may be normal in the first week of illness. Close monitoring of progression of symptoms aids in appropriate diagnosis. This is a diagnostic algorithm with the nerve root enhancement seen in spinal cord. Now we are having GBS with symmetric ascending paralysis. This is just a
I invite Dr. Srinivas. What is the answer?
Please go back to your history. And she was giving a lot of important clues, and then maybe Aparna, you can tell why she was telling all that. So one by one, go to the history. History. Yeah. Okay. Next. So no history of pain. She was saying paralysis and no history of pain. Why she was talking about pain? Sensory involvement, yeah. So which classic paralysis will have sensory involvement and pain?
An infection.
Huh? Myositis, it can be there. Pins and needles like of pain will be there in which condition? Nerves, like you can have it in GBS also. Okay, now no history of altered sensorium, seizure, headache, photophobia, and speech disturbance. Why did she tell about that? So she's trying to say that this is not a CNN problem. Okay. No drooping of eyelids, squint, blurring of vision. So which condition you will get drooping of eyelids and flaccid paralysis? So cry type of snake bite, botulism. These are the two important things you have to remember. Ptosis with flaccid paralysis, these two things. Squint and blurring of vision. Miller Fisher. So the type of variant she's talking about. No history of difficulty swallowing, drooling of saliva, no nasal twang, no change in voice. So pseudoverbal palsy. It again could be in your Bickerstaff or in your GBS, and also in any one of the things which can affect the ADM type of person. ADEM. So there could be encephalitis, myelitis, and also brainstem involvement. No history of deviation of mouth while eating. Facial. Facial also can be there in Miller Fisher as well. No history of bowel bladder involvement. Again, it could be because of the spinal. So bowel. No history of tremors. Cerebral absence. Okay. So she was trying to tell us that she tried to rule out each one of them. Next. No history of trauma. Traumatic myelitis, traumatic neuritis, animal bite, rabies. So which is very rare. Acute presentation of rabies is very rare. No history of recent immunization. She did tell about flu vaccine as well as and meningococcal. Pica. Very good. So lead poisoning is what else in these? Suppose we go to drugs. Drugs also. So just go back again to the same slide. Now tell me one of the diagnostic feature in each one of them. Now, if you have flaccid paralysis pain, what examination will tell us? The cause. Muscle tenderness. So you have to palpate or tap and see if the muscle tenderness is there. You know it is myositis. On examination, what will you find is that altered sensorium, seizure, headache, photophobia, and examination, what should you look for? One is meningeal signs and other is hypertension. Okay. Encephalopathy, that has features of encephalopathy, but blood pressure, you can check. Bradycardia, blood pressures can be features of raised ICP. Drooling of saliva, so we were thinking of drooping ptosis. Botulism is what we thought of, and viper bite is what, crater is what we thought of. So botulism, what will be the classical feature? Any examination feature will help us. Wonderful. So pupil examination will, they are dilated. Ptosis, dilated pupil not reacting, then you can think of botulism. Ptosis with dilated pupil is botulism. Okay. Yeah. So I wanted to tell when this she was presenting. When I was a MD, this was the same time of season. There was a child who came in the evening around 11 o'clock. We used to have a train from Saranpur to Chandigarh. Okay, so there was hordes of people come from Saranpur UP to Chandigarh. So that day, 11 o'clock, one child came and totally comatose, no movements at all. The child was well 1 day back, and the child parents said that he stopped talking, he stopped moving, and by evening he was not even moving. By the time from Saranpur to when the time Chandigarh he came, no movements at all, totally unconscious child. Examination wise, sensorium is not there, and all tone decreased, reflexes all diminished. Okay, so this is all things like acute flaccid paralysis. So it started with the face, started having the, so he was not able to move, he was not able to talk initially, then movements of upper limb decreased, lower limb moved, everything was. So by the time evening, nothing, he was totally paralytic. Then consciousness not there. So he was not able to move, he was not able to open eyes, and he was not able to, not even a single moment. Then we were very young residents at MD. So we thought this is probably encephalopathy, and severe encephalopathy, acute onset encephalopathy with sort of no seizures. But so we examined, we sent for all the investigations. Then one of our consultant came. She did just one examination, she said, and she spotted the diagnosis. What could have been the examination? Just one examination, and she said, this is this. No, sir. Was not there. Yeah, something like that. Yeah. So no smell, nothing. Yeah. So she talked to the child and she said, please touch my hand. And the child made a flicker of movement of the fingers. So the child just made a flicker of the movement of the hand, just the finger movement. And immediately she said she start anti-snake. Next day the child was walking in the unit. So it is a typical descending paralysis. So what sir was saying, it starts with the face, goes into the limbs, and then child becomes dull from the morning only, and then he will start not having any movements, and later all the four limbs will be affected. By the time he comes to us, obviously the ptosis was so severe that he was not able to move in, but hearing is preserved. The child was able to hear, but not able to make any movement. So the tip of the finger movement was still preserved, and that helped in making the diagnosis. So it is very interesting that crate bites, very rare, but in winter months, you should always keep this in your mind. Okay. So while I was listening to her, I was reminded of the case. I thought.
Thank you, sir. Thank you for sharing that. Even we presented similar case recently, sir. The child presented with the Iaptcb syndrome. We thought like it's brain dead and hypoxic with the travel coming from Angul. But immediately starting ASP and ventilator support, on 8 to 12 hours, we see starting neuro segment, child improved, and as is like next 24 hours, we expected and sent. This is a typical present of crate bites because they don't have any local presentation, only systemic elimination, and they present with this. So, thank you. You want to add?
The story is always serious.
That's
Money
true.
which you don't have. So you should try to pick up these little points. These are small, simple things which will. I mean, if you can listen to that one, you will never forget to examine that. You will talk to the child and ask them to touch at least the fingers. Especially regarding this case, the most difficult task was to convince the mother because the mother of this child was also a doctor. Initial presentation was like more cerebellar ataxia we were thinking of. So we even didn't go for any nerve conduction study or any even MRI imaging spine. We didn't go. But as the weakness progressed and the symptoms changed completely from ataxia, we changed into proximal muscle involvement. Then we counseled the mother. One more happy thing was she was able to understand because she is a medical person. So she got convinced, and that's when we counseled her. Probably is going into Iaptcb variant, and that's when we started on IVIG. And child had recovered just within 24 hours after completion of IVIG. So main thing is preserved reflexes. That's how we are always wondering could this be GBS because our entire nerve conduction study was normal, MRI brain was normal. We didn't even see it. Though we know that classical findings will be after 1 week, but we had given a trial because it's already day 5, but it turned out to be normal. So the only thing based on clinical and just an MRI spine, we went ahead and luckily child improved with that. So preserved reflexes could be definitely a variant with that.
When you start an IVIG, what is the rate of improvement? When how many days or hours you see that?
Yeah, like as per the literature, when we see there is no evidence to say which is superior or which is inferior. There are recommendations with 5 days regimen with 400 mg per kg or 1 gram per kg like 2 days regimen. But most predominantly that 1 gram per kg per 2 days is known to have more better outcome than the 5 days regimen.
It depends on the disability score of the
Exactly.
whether IVIG will like the recovery will be faster or not. the deficit is too much, like the biggest disability score is like 5, child is mental. Even if we divide it, it's not a-
That's correct. Right.
That is one thing. Second thing for prognostication is the nerve conduction. If there are absent CNAP amplitudes on the nerve conduction, that is a very high prognosis. So that, those are the cases we do for the person. So out of all these two are the ones which
The most important thing where I want to stress is we can tell the diagnosis or bad prognosis initially by these are called a bad markers for your GBS because GBS is a very routinely we see, but there are few which is like early ventilation, as you said, the absence of nerve conduction on serious. You can say that the prognosis can be very bad. It can go into 2 months or 3 months. Thank you, Vaidehi.
What is the breath count? So ideally, bedside monitoring is very important. Every day, the breath count, vitals, the involvement of the organization is there. Okay, I congratulate the team from Ankura for a well presented case. Vaidehi and mental proficiency. Let's move on to the last case. Another interesting case from Parmita Women and Children Hospital. I invite the presenter, Dr. Aparna. Mentor is Dr. Kiran Karthik. She will be presenting a case with of a 9-year-old child with vomiting and hypertension. With your attention to Dr. Aparna from Parmita. Yeah, please.
A 9-year-old female child presented with complaints of fever since 4 days and vomiting since 4 days.
A 9-year-old female child presented with complaints of fever and vomiting since 4 days. Just I not to mention the name next time.
Please tell me about the people.
Actually, after looking for child, we decided to work with art history of the child because he didn't appear normal first. So we have taken the history of she has difficulty in walking since 3 years of age and not gaining weight since 3 years of age. Like on exam, like directly shall I? Can you tell also?
You can go with whichever more important for the case. It's based on your chief complaint and
Okay. So tell quality features.
Yes.
As per your presence, you're going here.
So she's second birth born out of non-consanguineous marriage, and there were no complaints in the other children also, like what we had seen in her, like walking difficulty and not gaining weight in the other children. So other all history was negative, sir. There was not significant to our case. Actually, sir. On examination, we have found this, like on chest examination, we have seen ricket rosary appearance of at the costocondral junction. Upon seeing this, we asked the child parents about the treatment history for any vitamin D deficiency. So they have given history at the age of 3 years. They have taken vitamin D supplementation for 1 month, and they have stopped by themselves. They didn't go for follow-up or any other treatment. They haven't taken anything. So there is big widening of the at wrist joint, and this intercondylar distance was greater than 10 centimeters, sir. And the lower limb deformity was greater than the upper limb deformity, and there was muscle wasting in the child. And on trigonometry, the child was the height and weight of the child was less than third centile for her age group. The other systemic examination was normal, sir.
Also said there is hypertension.
Yeah, sir. The vitals were normal, sir. Only blood pressure was greater than 90th centile, sir. There was nothing significant anything, sir. Only the blood pressure was higher, greater than 99 centile.
It's a liquid like illness.
Yes, sir, with hypertension. So the summary, the child was a 9-year-old child with vomiting episode, normal birth and development history, failure to thrive. On examination, we have seen features of rickets and normal systemic examination. So my differentials was like nutritional rickets, because the child appeared to be like that. And the lower limbs was deformity in the lower limbs was greater than the upper limbs. So we thought it would be non-nutritional like hypophosphatic rickets, maybe by this. And the hypertension might be the complication of this due to kidney involvement or something like that we talked.
So, see, I'll just tell in the favor of clinically whenever you use something. So, what is the dietary history? Did you mention the dietary history for this time?
Dietary history, the child was taking
Adequate.
calcium and phosphorus.
So only whenever you suspect any nutritional deficiency, it's not like only one vitamin. We see other. So they are normal. So that's what any clinical approach always coming from the history taking. So nutrition is normal. So I would like to put nutritional not first because you're saying nutrition diet is normal. So I want to put something else because as the child is presenting with the lower limb involvement more and nutritionally is good. So non-nutritional rickets should be the primary diagnosis compared to nutritional. If
weight and height was very significant.
okay.
It's 9 years and weight was only 16 years.
Okay. So you want to put any organic disease again rather than nutrition? I think you can put an organic chronic disease or anything. You can put that first and going for the nutritional is better. Okay. Any other clinical history you want to say for rickets other than this? Anyone in the Dr. Alpha? You want to put how to go with the case of rickets? What is the history you ask? What will be the significance for antenatal history for the child of 8 years? Huh? 8, 9. Not that useful. Whenever you see it less than 3-4 years, that will be useful. Any other one?
What was in your mind when you asked about going at
Tubular acidosis, maybe the
Tubular.
Same thing, sir. Like I asked it because of growth hormone deficiency, also present with constipation and renal tubular acidosis also. Vitamin D deficiency might be the cause for recurrent respiratory infection. Hypocalcemia may be a precipitating factor for recurrent bone fractures.
what drugs you are, madam?
So actually, I was suspecting like if the child may be on an AEDs or any antacids.
Never, sorry for interrupting you. Please, whenever you present a case, and especially if you are a DNB, don't use the word any, because that says that you are just asking the examiner to have a differential like for yourself. use specific words. As sir said, what are the drugs which may cause bone fractures? If you know that, tell the drug and it can be a complication for that.
Chronic drug use like antacids increase the vitamin D metabolism.
I think
So
Kiran can help her for this. And going for the next, any other positive you want to add? Because it's clear cut, it's showing like a rickets. So narrow down into your nutritional or organic or renal. So do you have any clinical approach to say it is renal? Yeah, okay, fine.
Proceed.
Investigation we find hemogram was normal. Hemogram was normal, sir, and all RFT and LFT were also normal. ABG was also normal. In view of hypertension, we suspected like nephritis in the child acute presentation. So we have done this CUA examination. Because mild protein fever was present. Other things was normal. So initial investigation suggestive of like only phosphorus was low, sir, and ALP was highly elevated, and vitamin D and parathyroid hormone was normal. So, like our approach to the child was we are suspect it like 9 years old child, and they have taken some sort of treatment also. Maybe it might be the refractory rickets. So we decided to do serum creatinine to rule out any renal involvement. So if the creatinine was high, maybe we can suspect CKD along with the hypertension was present in the child. But creatinine was normal, sir, in our child. So like we suspected like any
Only creatinine can be used for CKD, or we have any other to diagnosis with the CKD? Decrease urine, you can see even in acute. Do you have any other to say? One thing is JFR and but because in most of the CKDs they may present initially with your serum creatinine normal. So going with a lab it is difficult. So it's more ultrasound. If you do an ultrasound, if you have a small kidney, again that is even if your creatinine is normal and function is normal, smaller kidney compared to the age, you can suspect it as CKD. Any other things? Kidneys, that's what. That's the reason I asked you. Mention it is. So, okay, fine. Next.
So like the appetite was normal, so we decided to do ABG to rule out any RTH. It was also showing normal. Was no acidosis. So like we went to see for calcium and phosphate. So calcium was low normal and phosphate was low in our child. So likely the presentation of like hypophosphatic rickets to hypocalcemic rickets. In this child, like our child presented with normal, she didn't find like 6 to appear, and she has more lower limb involvement. And to this, there was normal PTH and normal calcium level with low phosphorus. In this, like
PTH is the one which is going to differentiate in calcimic and hypophosphatic. We had normal PTH, so we were suspecting hypophosphatic.
So we have to bring in what is glaring clinical feature. One is rickets. So far, very good. About the hypertension part.
hypertension, like
We have to consider hypertension at every step, isn't it? So, what is your take on that so far? So far, you have presented well. Next.
so maybe renal cause we have suspected in that child.
Please proceed. Let us know.
That USG abdomen we have done so. So
that kidney were bulking size with increased echogenicity, and there were corticomedullary differentiation was noted, sir. And renal Doppler appeared to be normal.
Okay.
So in view of hypertension also, only we have taken 2D echo, which was also normal, sir, because acute presentation with vomiting is hypertension.
Right.
So as the child PTH was normal, so we suspected hypophosphatemic rickets. This is a proforma for hypocalcemic rickets. Like if the calcium was low, and we have to proceed with the 25 hydroxy vitamin D. If it is also low, it is like proof that vitamin D deficiency. But in this child, the vitamin D was normal. If vitamin D was like 25 hydroxy vitamin D is normal or high, next step we have to perform like 125 hydroxy vitamin D. If it is come to high, like resistant, like receptor deficiency, we can suspect, sir. If it is normal or elevated, we can go for hypocalcemia, like calcium deficiency only we can suspect. If 1,25 hydroxy vitamin is low, like it is suggestive of 1 alpha hydroxy deficiency. In our child, like the findings were low serum potassium and low normal calcium with increased ALP and normal vitamin D and parathyroid. So we if we suspected hypophosphatic rickets, and in that also, if there is phosphate loss, like if there is a we next decided to do what kidney absorption is present or not, like. So in our child there is renal phosphate loss, sir. So we have in this case, like renal phosphate loss was there. In that also, the next differential diagnosis we are suspecting like X-linked hypophosphatic rickets or like that. In that, so we decided to do 1,25 hydroxy vitamin D. In that there are two types, sir, like FGF23 mediated. In that, 125 hydroxy vitamin B will be low. The other case, which is associated with hypercalciuria, in that condition, like 1,25 hydroxy vitamin B will be on higher side. So in my child, we performed like fractional tubular reduction phosphate level value. So it came out to be 0.7, like 0.86 was normal. In our child, like 0.7, it has cancer. It indicates that there is definitely a loss of phosphate in the child. And like in this child, my child, like 1,25 hydroxy vitamin D was on higher side, just above the normal. And there is no hypercalciuria, like as we mentioned in this slide. To differentiate between these two, like we came up
This
to
what information we got is that there is definitely loss of phosphate.
Yes, great.
That is what we got, but there was no loss of other elements.
Okay.
So there are only two diagnoses which we can do. One is FGF mediated, which was not probably because 125 was on the higher side.
Yeah.
If we go to the other diagnosis, where there should be hypercalciuria, which was also not there in one case. So this is where we are stuck up.
This is fine. My point is, I am eager to know the cause of hypertension. I am looking for a disease where I can explain my rickets, which is more common on the lower limb, plus all your findings where you are losing the phosphate, plus I am eager to know the cause of hypertension. Because clinical findings like rickets have worked out very well. We cannot ignore the hypertension. What I am given to understand, hypertension is not equal to just echo. What you told hypertension, have you seen all the 4 limbs?
yes, sir.
Okay.
Only thing was there were RBCs and 1+ proteinuria was there.
Fine.
But C3 was on a normal side.
Okay.
And only bulky kidneys were there. These
Okay.
are the things which were favoring after geometric state.
Right.
But we thought this should be an association with already present disease with hypophosphatic.
Okay.
But there are case reports saying that if there is hypophosphatic, secondary hyperparathyroidism. This can activate the aldosterone system and can lead to hypertension.
Yeah.
But this is not the present case because parathyroid levels are normal. So we thought of association of AGN and hypophosphatemia.
Azotical is done.
Azotical.
Three was normal, sir.
Any anti-nuclear antibodies were done.
No, sir.
Okay, can you proceed further? Is there anything you want to contribute?
No, we want to know what is the next step.
Yeah. I invite your mentor, Dr. Kiran Karthik. Now you can, in the interest of greater audience, be clear, please.
As we can see, sir, we have followed the flow charts, and this child is classically not fitting into any of the diagnoses. One thing we are assuming is this because the child might have had some acute kidney injury, which had led to the abnormal renal phosphate loss or some disturbances in the calcium. That is what we are assuming. So what we planned is that we should review the child after 1 to 2 weeks. Once this resolution is over and this hypertension is getting controlled, then we thought of again repeating the investigations what we have done, like urinary calcium phosphate, so that we can get a clue. And we were also thinking of doing genetic analysis. Maybe that will give a clue because PATS gene, all these things will be present in hypophosphatemia rickets. These things were which we were considering. Anything else from your side, if you can suggest, that would be helpful.
I want to ask, like, see, whenever you say hypertension or anything chronic, so can you tell clinically, is there any point towards acute hypertension or is it a chronic hypertension? Because that can give you information whether the child had any CKD or the real renal problem is causing all rickets, because renal can present with the rickets and hypertension. So is there any chronic hypertension features you have? What are the other signs or symptoms you see in a chronic hypertension? Anyone? Because I always wanted to in a clinical approach rather than the investigation. So hypertension, did you check any Pablo's? There is no any flares or nothing. So what are the other examinations for hypertension you do? You ruled out by one Doppler saying that the cause was because hypertension is 99. There is a malignant type of hypertension you are seeing in this child. So you have to know the cause or you have to treat it. What might be the intercurrent causes you see? One. Okay. Clinical. Tell me the clinical, because if you open the Nelson, you have 5 to 10 points where you are with hypertension asking station quality in this examination of child with hypertension. Coming from head to toe. One is your retinal examination. Next. Eyes. Stature. How does it related to stature? Cushing's, very good. If there is a short stature female child, what do you suspect? With a webbed neck, Turner's copter they can present with hypertension. Next. So you auscultation on the back, you see any continuation of murmurs. Next. Vasculitis, skin rash, skin rash. That's the reasons are asked you. ANA propeller for any SLE, male or female SLE, they can present with your hypertension in them. Any other things? You always, because sir and me want all clinical approach more of. Any mass? Very good. So any renal mass or adrenal mass present, or your renal pathology, or auscultation of the renal area, hearing something, renal fluid that can say in your renal vascular disease. Okay, this is the way, whatever you said, you have to diagnose. If it is a chronic hypertension, then again I think we have to put as CKD is causing all the issues when compared to, because if you have any. If not, I think how is the child now is treated with?
Hypertension is coming down.
Okay.
And, there are no other symptoms related to hypertension.
So that again says I think it's an acute presentation, because if the child is responding with your hypertension drugs, then it's always think in acute presentation.
Probably some post-infectious nephritis.
Yeah, that's what AGN or Very good. That's one of point clinic evidence based, but you have an ventricular hypertrophy or septal hypertrophy if you have a chronic hypertension. Okay. Thank you. Thank you. Well present. Good case.
You can take this as AGN, but you could have worked up for ASO that will be at low. And any previous skin infections are there. And maybe we need to follow up on it.
One more point here, I think CPC will be here normal initially. So if it is after 2 weeks, then we make it like. Initial will go see. And limit of calcium and creatinine ratio is also important because it might be done on the one side.
One more thing which I would like to ask, like, how do you counsel the parents? Because first you had said 25 hydroxylase level telling the as vitamin D, and again on repeat further you went for again 125 hydroxylase level. So like, is it better to send both 25 and 125 at the same time, or you do it in a phased manner? Because they might tell you just 2 days back only you send vitamin D level, and again you are sending something.
These are the
This is a
practical.
very difficult question, sir. But if you are in a private practice, you might tend to do everything. But only thing which we had in favor was that this child has been suffering from a long time. The child has been affected from 3 years at least. So they also want an answer by the. So they were cooperating. That is one thing which we have done.
But I'm sure we had a good session of many cases, starting from rare case of Guillain-Barré from Ankara Hospital. Then hypothyroidism presenting at short stature from Europe Hospital. Then to the chest, that is eventation and sequestration of the lungs, which is very rare. And now we have another interesting case from nutrition part, that is the rickets, hypophosphatemic rickets with the hypertension, whether it is coincidental. Research continues to catch that fancy disease, which is musculotic. I hope with time everything will be clear. Is it essential? Is it primary hypertension of that age? Your child is 8 years, can't be. What are the differences? Primary hypertension, secondary hypertension, clinically. Like, that we alluded. Right, thank you everybody. I thank all the presenters and the enthusiastic discussion, Dr. Srinivas Murthy sir. I know Dr. Subramanian sir is on Zoom. We could reach his voice. Thank you, Dr. Subramanian sir, for your time. And I thank Iaptcb President, Dr. Bhaskar sir, who always encourages us, and RSV Sri Krishna. Over to the organizers, President, and my co-chairperson, Dr. Srinivas will speak.
Really thank for giving this opportunity. Being a most junior in this healthcare area, it's happening because academics is the one I was very interested from past 5 to 6 years, and TC, I really congratulate and thank TCB for organizing so many every month, because being a pediatric resident in Hyderabad to becoming a consultant, we lacked a lot of academics, pediatric academics when compared to Mumbai and Chennai. So I really thank Sugar Bhaskar sir for putting a great effort and taking academics as a priority. When you compare to the previous IAP, academics as a priority, and they are involving and everyone. So really thanks for giving this opportunity. I hope we'll do this more in this part of Hyderabad. Thank you, sir.
I thank both Srinivas for doing a wonderful job. Really, we learned so many things from these experts. And I'm so happy today I could find one more young upcoming star academician, Dr. Srinivas Medley. Thank you very much. And I thank all the presenters, mentors, and all the attendees for making this program a very useful one. Thank you, Aranda. Again, we have a symposium on this coming Sunday, that is 17th. It's neonatal nutrition. And it's being organized mainly by Srinivas Murthy along with other a team of neonatologists. It's a virtual program. We'll send you the link. Kindly participate in it. So thank you, Aranda. Good day.
Thank you. Thank you. Thanks.
Yeah, I've been. You are all 4 from
Yes, sir.
Yeah,